All right, there were several things here that we found, but I want to go to the biggest finding first, and that is when we bring it around to the front. Let's dissect this. We'll bring it all the way down. Okay, so the biggest finding we found is that the first ribs are subluxated, dislodged, should be up here on both sides. So this thing is dropped, and we measured it 5 millimeters. It's dropped 5 millimeters. Here you can see this, the first rib, and you can see where the facet where it used to be attached. It's just barely down there. I've seen it completely dislocated on another person, and I've seen other people where it's down on one side and not the other, but you've got it on both sides. And you look at that, you can see this is where the facet is, and they're both 5 millimeters dropped on both sides. So we have, this is an Ehlers-Danlos Syndrome, 3+, and here you can even see how close these two ribs are approximating each other versus the rest of the rib cage. Now, what happens when this happens? Well, a couple things happen. The scalenes are the muscles that stabilize the neck, two of the big muscles that stabilize the neck. So they're not able to modulate and stabilize correctly when these first ribs are down like that. Another thing, probably the chief thing, is that the stellate ganglion sits in front of here. And everybody's anatomy is a little bit different. Some people, would just be, dislodging it, the stellate ganglion bilaterally. Other people would just be putting a great deal of force behind it. But I don't think you can get away with this not bothering your stellates. Now, what are they doing stellate ganglion blocks on these days? Well, not just these days. Back even in the 50s, they started off, or didn't start off, they've been doing post-traumatic stress disorders. They've been treating all kinds of things by doing stellate ganglion blocks. And it started with our guys came back from World War II. And I think what it was those heavy tactical vests, running with those. I think that's what dislodged the first ribs on them, causing the stellate ganglion to get irritated. Now, the stellate ganglion is part of the sympathetic chain, and it overrides the parasympathetic once that thing's being irritated like this. And you're going to be stuck in fight or flight. You're going to have a hard time settling down. Your digestion's not going to work right. All kinds of crazy stuff's going to happen. Vagus nerve is going to function as if it's not functioning because it's being overridden by the sympathetic. So I think you're going to have a hard time modulating your emotions and actually digestion and all kinds of things. And, well, quite frankly, it's going to be easy for the doctors to blame you instead of your anatomy. Okay, so Ehlers-Danlos, what do we expect? Well, we expect subluxations, we expect hypermobility, and we have it. Here you can see the atlas goes up to the left too much. Here we have her turning her head to the left. Now, when she turns her head to the left, C1 doesn't come off as C2 too much. It could be argued that this is moving too much rotation there, a lot of rotation there, really a lot of rotation there. This one's just sliding for all it's worth. That's with left rotation. What else do we see? Here we're seeing a paradoxical thing that we've seen. C1 is moving off of C2, I'd say a little too much. And when that happens, sometimes there's a paradoxical motion where C2 is not rotating to the left. So here we can see C2 rotated to the right, C1 to the left. All these other joint spaces are closing like they're supposed to. So you just have this paradoxical thing there. Then when we turn to the right, well, one thing, when you turn your head to the right, the atlas goes a little too far up to the left. So when it comes to you slipping your adjustment, it would be moving your head to the right too much. That's where you're vulnerable. Again, with right rotation, C1 doesn't seem to be coming off of C2 too much. That joint not moving too much. That one's telescoping. That one really does move quite a bit. Look at the space there. And that one's the most. So right in there. Yeah, again, they move a little too much. Let's see, that's the hypermobility. Let's see what else we got here. Okay, so these are the Atlas orthogonal images. Your Atlas has gone up to the left. C2, now this is weight bearing. These CT scans are with you supine, no weight bearing. Here we have C2 spine is to the left 15.3 degrees. That's a lot, and that's probably what's giving you a lot of your symptoms, the open joint capsules in the back. Now we've seen this with a first rib, and I think this first rib is what's causing these scalenes to not stabilize. Scalene, the middle scalene attaches to C2, so I'm seeing that as a problem. That was that. What else did we want to talk about? We put so here we put a 5-pound weight around your neck. There's a weight coming this way to help return the curve. That made you feel better because we think it's closing these joint capsules. We also have a Chiari 0, so it's going to put some slack in the cord and help lift the brain up a little bit. So that might have been what you were feeling, made you feel better. We're a little concerned about putting a weight around you too long because these first ribs are, I think, the primary thing. So again, I guess I didn't really speak to what to do about these things. So now we have, good thing we have Prolo doctors and people that do PRP. So what would we want? We want Prolo therapy, stimulant injected all through here, all the way, even with video fluoroscopy, all the way to the vertebral body there to tighten up those ligaments to lift it back up. And of course, a stellate ganglion block sure would be nice. You would think. I know guys that would want to do that. Let's see. Prolo, PRP. Well, it would be these joint capsules that move too much, and Prolo to tighten up the posterior elements all the way around because you move too much. All right, so we also saw, let me back this out. We also saw a calcification of the stylohyoid ligament here, digging into the jugular a little bit. We did have you jut your jaw forward in this particular scan over here. Let's back that out, or rebuild it, I should say. And let's bring back the vein. So when you jut your jaw forward, these calcifications move away from the jugular, which is what we want, and opens that space up. We also have found with other people with Ehlers-Danlos Syndrome, and actually just traumas to where the ligaments are torn and loose, that when they jut the jaw forward, there seems to be a stabilizing force helping them to stabilize the neck when they transition from lying down to upright. So we've had people that have had all kinds of Prolo and PRP and great adjustments and physical therapy, and yet still have an instability there because when they transition from lying down to upright, the ligaments are just not quite tightened up there. And once they jut their jaw forward for 6 weeks, when they go from lying down to upright, it seems to stabilize it. We also are big fans of the dental appliance that you have. Your dental appliance is set for anterior 2 millimeters. We want to adjust that to 3 millimeters and possibly 4 millimeters to see if that doesn't help you stabilize these. I think when you get Prolo and PRP now that they're going to be just addressing the first rib and getting those scalenes to modulate and stabilize you, I think you're going to get a lot more efficaciousness from the regenerative medicine. Did I touch on everything? Any questions? What did I miss? Oh, the sleep apnea in the airway. Thank you. I did forget to mention that. Let's bring that up. So again, our experience with this is that we've got people that are, okay, here we go. Now we got orientation right. So you have a narrowed pathway in the back there. So holding your jaw forward would open the airway a little bit. We're big fans of positive pressure. So we want you to be able to, get the CPAP machine working for you. Get the nasal pillow, which will pressurize it in this direction. You can sleep with some tape on your mouth to make sure it stays closed, and or that dental appliance that holds your jaw forward. We don't want the jaw open at all. Here we are looking at your airway from the front. You look pretty good here. Again, this is just imaging. It's not a functional test. It's not the end-all be-all when it comes to airways. Actually, when it comes to airways, experimentation beats theory. We've got people that have lost a bunch of weight and they don't test as being having sleep apnea anymore, yet when they use their CPAP machine, that it does oxygenate them and make them feel a lot better. So again, functional medicine doctors, we care about running experiments to find out what actually improves your function. Heck, we could do a B12, a blood test on you and say that you're not really deficient in B12, but your B12 is not optimized. So we want to optimize everything we can find on you. Optimize venous drainage, optimize airflow, and again, treat you like an athlete. What actually makes you feel the absolute best, not just deficiencies and frank pathologies.
I know you didn't see this on imaging, but for the sake of having it more thorough for my chiropractors and other physicians, can you talk about the hiatal hernia?
The hiatal hernia. So thank you for bringing that. We've had great results with this hiatal hernia. So again, this was a move not taught in college, but it was taught by an old chiropractor who's long dead. An old chiropractor probably taught him. And he said that even before that, the way they've been doing it throughout time is that they would fill up the stomach with a liquid and have you jump off of a step stool. So right now, we've been adjusting these hiatal hernias for 3 decades. And what happens is that the stomach will pop up through the hiatus of the diaphragm, put pressure on the heart and lungs. We've had people that have been worked up with heart catheterizations and all kinds of things. The heart's fine, yet it was this either a structural pressure from actually having a stomach occupying space in the thoracic space, or the autonomic nervous system not liking that. And I believe it's definitely the autonomic nervous system is in play, because we've adjusted these hiatal hernias, and some of the vascular symptoms that people have seem to get better, and it's kind of like a dysautonomia. Once you start having these injuries that are not treated and found in short order, and they go dystrophy going on, or some sort of ill-defined dysautonomia. And just like a double crush injury we can have in a peripheral nerve, you can have more than one injuries that are affecting the autonomic nervous system, and it seems to become greater than the sum of their parts. So we've treated hiatal hernias and then adjusted an Atlas, and it's almost like that's what the nervous system needed to settle down and finally go back to parasympathetic and not being stuck in sympathetic. But in your case, I think these first ribs definitely have to be dealt with, and that stellate ganglion, that's what's driving you in this sympathetic, and your digestion's turned off, you're not going to digest well. And you know, what came first? Running around as a kid with a heavy backpack, bringing these first ribs down, irritating the stellates, which overrid the parasympathetic, and now your digestion is not robust, and you end up with a connective tissue disorder. I don't know, these are all speculations.
I guess time will find out as we treat him and see.
Yeah, you treat things in a different order. In what order? You know, God will guide you. You're going to prayerfully consider what to do in what order. The Lord will lead you out of here. He did not even bring you this far to forsake you. Jesus loves you so much he can hardly stand it.
Did you tie in the L3 adjustment for the spine? Or is that necessary for this discussion?
I don't think that's necessary.
Okay.
Any other questions?